All right, let's get into it. There's one drug you're going to encounter on day one of your anesthesia or ICU rotation that can put a patient to sleep in literally 15 seconds. It's powerful, it's versatile, and you absolutely need to understand it inside and out. Today, we're breaking down Propofol. The answer? Propofol. And those three characteristics you see right there, the lightning-fast onset and the total lack of pain relief, well, those are the keys to everything. They dictate how we use it, who we can give it to, and what we have to watch out for. By the end of this, you'll get the why behind every single one. So here's how we're going to tackle this. We'll start with the absolute basics, then dive into how it actually works on a molecular level. We'll follow its journey through the body, cover the critical safety checks, and then wrap it all up with the clinical pearls you'll need for the wards and, yes, for your board exams. Okay, first things first. What exactly is Propofol and where do we use it? Let's get our foundations totally solid before we move on. So technically, Propofol is what's called an alkyl-phenol derivative, but in the clinic, we just know it as a hypnotic agent. Its job is to induce unconsciousness. That milky white look is iconic, right? And it's because the drug is dissolved in a fat emulsion, usually soybean oil and egg lecithin. Now, I want you to file that lipid base away in your brain. It's the reason for some of its biggest risks. And its versatility, it's pretty incredible. In the operating room, it's used to put people under for general anesthesia. Head over to the ICU, and it's providing sedation for patients on a ventilator. It's also perfect for quick procedural sedations, like popping a dislocated shoulder back in place. And in the neuro-ICU, it has this really cool side benefit. It actually lowers the brain's demand for oxygen, which helps bring down dangerously high pressure inside the skull. Okay, so we know what it does, but how does it do it? Look, understanding the mechanism of action isn't just about passing exams. It's the key to predicting its effects and its side effects. So before we can even talk about Propofol, we have to talk about GABA. The easiest way to think about GABA is as the brain's main braking system. When GABA binds to its receptors on a neuron, it tells that neuron to chill out, making it less likely to fire. This is what calms the nervous system down, reduces anxiety, and helps us sleep. So how does Propofol hijack this braking system? It's a GABA agonist, but with a really interesting twist. It doesn't actually step on the brake pedal itself. Instead, it's like it makes the brake pads hypersensitive to the slightest touch. It latches onto the GABA A receptor and basically supercharges the effect of the GABA that's already there. This opens the floodgates for negative ions into the neuron, causing that profound CNS depression we call sedation. All right, let's switch gears and follow the drug's journey through the body. The way the body handles Propofol is exactly what makes it such a predictable and incredibly useful tool for us. This combination you see here, an unbelievably fast onset and a super short duration, that's the magic of Propofol. You push the drug, the patient is asleep in under a minute. You stop the infusion, they're waking up in about 10 minutes. This is all thanks to rapid metabolism in the liver. And this gives us this amazing, precise on-off switch, which lets us do things like sedation holidays in the ICU, where we can pause the drug to quickly check a patient's neurostatus. I mean, just pause on that number for a second, 15 to 45 seconds. That's the time from the drug hitting the vein to the patient being completely unconscious. This incredible speed is exactly why Propofol is a go-to agent for rapid sequence intubation, or RSI, when we need to secure an airway in an emergency and we need to do it fast. Now, because this stuff is so potent and acts so fast, we have to be extremely careful about who we give it to. This next section is all about patient safety, so listen up. This is absolutely critical to understand. The difference between an absolute contraindication and a situation that just requires caution. An absolute contraindication is a hard stop. A known allergy to propofol, eggs, or soy, you cannot use this drug, period. Then we have the red flags. For patients with fat metabolism disorders, that lipid load can be a real problem. And in patients who are dehydrated or have heart problems, propofol side effects can be dangerously amplified. You know, every drug has side effects, but with propofol, you really need to have two clear mental buckets: what's common and expected versus what's rare but catastrophic. This is where your clinical vigilance really matters. This slide basically shows you those two buckets. On one side, you've got the stuff we fully expect to see. Propofol causes blood vessels to relax, and it dials down the central respiratory drive. So a drop in blood pressure and breathing, we anticipate that and we manage it. But on the other side is the one thing you can never, ever forget: propofol infusion syndrome, or PRIS. PRIS is a clinical nightmare. It usually happens with high doses of propofol given for more than 48 hours. The body's metabolism just gets completely overwhelmed, and it kicks off this devastating cascade of failure. The blood becomes dangerously acidic, muscles start breaking down, the kidneys fail, and then the heart just gives out. This is exactly why long-term propofol infusions are only for the ICU and demand incredibly close monitoring. So let's bring this all together. How do you take all this science and apply it safely and effectively when you're standing at the bedside with a real patient? The easiest way to remember this is a simple 3-step safety check. Before you even draw up the drug, check for those critical allergies and make sure your patient's blood pressure is stable enough to handle the drop you know is coming. During administration, your eyes are glued to the monitors, heart rate, BP, and especially their breathing. And for those longer ICU infusions, you're constantly on the lookout for rising lipids and any early signs of PRIS. Now, you might be thinking, why explain it if they won't remember? Well, compassionate care is also for the family. You'll let them know it will cause a deep sleep, that you'll be monitoring constantly, and that it's totally normal to feel groggy afterwards. And this is non-negotiable. They absolutely cannot drive themselves home after sedation. And here it is. If you remember one single thing from this entire explainer, make it this. This is the classic board exam trap. A patient on propofol might be unconscious and totally still, but they can still feel pain. It provides powerful sedation and amnesia, but, and I cannot say this enough, zero analgesia. For any painful procedure, you must give a separate pain medication, like an opioid. Never, ever forget that. So, I'm going to leave you with a little clinical puzzle to chew on. Think about a patient who needs a brief but painful procedure, like getting shocked back into a normal heart rhythm, or maybe a brain-injured patient who needs sedation but also needs frequent neuro checks. Based on everything we've just covered, its rapid on-off time, its lack of pain relief, its effect on blood pressure, when would propofol be the perfect tool for the job? Thinking that through will lock in everything we've talked about today.